Good day, and welcome to the 0 to 3 Case Studies in Supporting Enrollment Efforts Conference. Today's conference is being recorded. At this time, I'd like to turn the conference over to Ms. Kathy Reschke. Please go ahead.
Thank you, Justin. It's great to be with you today, everyone. As Justin said, my name is Kathy Reschke. I'm the e-learning coordinator for the MIECHV Technical Assistance Coordinating Center, and I'm going to be your facilitator today. On behalf of the TAC, I want to welcome you to today's webinar on strategies for supporting local implementing sites enrollment efforts. As most of you know, the TAC is funded by HRSA and staffed through 0 to 3 and our partners Chapin Hall, AMCHIP, and WRMA. The TAC provides different levels of support to MIECHV grantees, including these webinars, using 0 to 3 and partner staff, as well as expert consultants. As you can see from the slides, our objectives for today's webinar all center on thinking through the challenges of meeting enrollment goals and strategies that states can use to overcome those challenges. We have got a full agenda for today's webinar. You should have received an email yesterday with the link to download your pre-webinar registrant packet. In that packet, you can find detailed biographies of all of today's presenters, as well as a PDF of these PowerPoint slides for today, and also a couple of the tools that will be mentioned by Rob and Mary Beth. So if you haven't downloaded it yet, be sure and do that so that you can follow along. To start off today's presentation, we're joined by Julie Ross. Julie recently became Chief of the Eastern Program Implementation Branch of the Division of Home Visiting and Early Childhood Systems at the Maternal and Child Health Bureau at HRSA. Congratulations, Julie, and thank you for joining us.
Thank you, Kathy. On behalf of Dr. David Willis, Director of the Division of Home Visiting and Early Childhood Systems in HRSA's Maternal and Child Health Bureau, our project officers, and other HRSA staff, welcome to today's webinar for grantees of the Maternal, Infant, and Early Childhood Home Visiting Program, or MIECHV. Senior leadership at HRSA and senior staff within the Department of Health and Human Services use enrollment data provided by MIECHV grantees as a measure of the success of our program. As our grant program matures, the expectation is that at the state level, MIECHV grantees will be able to maintain at least 85% capacity. HRSA views capacity as a function of the maximum number of families that can be enrolled at the current annual funding level. Project officers are actively engaging grantees in conversations about their enrollment numbers, and division leadership will work to more uniformly define the meaning of capacity so that we can include it in future funding opportunity announcements and formal communications to grantees. HRSA hopes to begin conversations with model developers to better define capacity for MIECHV grantees as well. Today you will have the opportunity to hear more about the work of the MIECHV Collaborative Improvement and Innovation Network, which is a high priority for HRSA leadership. This kind of collaborative improvement work is seen as a strategy to strengthen the case for continuing support and sustainability of our MIECHV program. We believe that this project can amplify the contributions that states, local implementing agencies, model developers, researchers, and other stakeholders are making to the field of home visiting. Today you will hear about some of the strides grantees have made in implementing the model for improvement to improve enrollment at the state and local levels. We hope to have more forums to discuss this ongoing work and encourage grantees to reach out to your HRSA project officer if you would like to receive more directed TA or be connected with other grantees as you go about improving enrollment numbers in your state and communities. Thank you.
Thank you for those comments, Julie. We really appreciate it. Now I'd like to welcome Mary Mackrain. Mary is Project Director for the Home Visiting Collaborative Improvement and Innovation Network that Julie mentioned, more commonly known as the Home Visiting COIN. We've asked Mary to share her work with the Home Visiting COIN, particularly around enrollment. So, Mary, thank you so much for joining us.
Sure. Thank you, everybody, and thank you, Kathy, for giving us the acronym so you guys don't have to hear me say what the Home Visiting COIN is more than a few times here. So from this point on, I'm going to refer to the project as the Home Visiting COIN. So I'm really excited to be here today. I'm excited that I am part of this Home Visiting Collaborative Improvement Network. It is an exciting project, and I work with the Education Development Center, who is collaborating with HRSA on behalf of this project. So I really want to state just from the very beginning that it's the state grantees and the local teams, the home visitors, the families, everybody working together to make this program have all of this initial success and excitement around it. We have a lot of early adopters, people who are really passionate. So our program is 100% voluntary. So the people that are part of it really wanted to be, and we're starting to see some of the early effects so far. We've got a long way to go, but I'm excited to share some of our information. So this topic of enrollment is of particular interest to me as my professional beginnings really took place in the homes of many, many families throughout the city of Phoenix. So I saw families struggling with the effects of trauma, broken relationships, and unfulfilled basic needs who I remember well at the onset of services and home visiting were very unsure of who I was and what I had to offer. So for many of these families, perhaps services hadn't gone well in the past. And I know from my own experiences, like all of you do probably as well, that enrollment takes intentional and sometimes challenging effort, often leading us to change our regular way of doing things, which can be overwhelming and so forth, but we have to do it in order to set the trajectory right for families, for babies and young children as early as we can. So today I'm going to share just some of our early work of the Home Visiting COIN as 35 teams across the country have embarked on small, rapid tests for improving enrollment. So on this next slide, I love this photo. This little guy is taking a look at us and saying, what are you going to do to enroll me into your program and support my family? And I think about, after reading Deborah Darrow's work, like many of you probably have as well, she has developed with her colleagues an integrated theory around engaging families, which focuses on 3 points of engagement: that intention to enroll, the enrollment itself, and then those decisions families make to stay enrolled. So in other words, as you see on the screen, I want it, I'll try it, I'll stay. And I think all of us, really that's what we want. We want families to say, you know, I want this. I think I'll try it out, and I love it so much. I feel my outcomes, my needs are being met. I'm going to stay. So how do we get there? That's the challenge, right? We know that at every point in our home visiting process, families are continually weighing the cost-benefit of our services, which gives us an opportunity to up our benefit during every single encounter. With our calls, with our texts, with our visits, every single encounter is an opportunity. And in some ways, I think maybe you agree that this is what can make our enrollment process so complicated. We have all of these critical and multiple elements to consider. For instance, what is the family's first experience when they're referred? Has someone spent time talking together with the family about what they see as the benefit of home visiting? What past experiences have families like the ones you see on the screen dealt with in the past? What are they hoping for? So, you know, as I think about the research, and I've listened to teams talk in our Home Visiting COIN project and listened to faculty talk, we come across these common enrollment issues that I think probably everybody can relate to. We know that when families have to wait a long period between the initial assessment and the first home visit, that's well, I guess I wouldn't use the word opportunity. It's a time period where we can often lose families if the wait is too long. So if 2 weeks or 3 weeks or 4 weeks goes by, we can often lose families to other things. They may lose interest and so forth, or we may not be able to grab their intent and get them into enrollment and get them to stay. We know that research around enrollment and engagement is complicated with many variables, and we don't have strong enough evidence base in terms of knowing what exactly works. What should we all be doing? And again, it's complicated because we live in rural and urban areas, and we serve different families with different cultural backgrounds and so forth. So it becomes complicated. But the other piece is messaging, too. Sometimes I wonder, is there a common understanding at the state and local level about what enrollment actually is, how it works, and subsequently how each person understands and messages this to families? So enrollment doesn't always mean engagement, but it is a first step, and the relationship is critical. So you can see I highlighted the word relationship, and I'll relate this to the home visiting coin, and then I'll get into some of the things that we're trying within our project here. But if we think of this team effort of serve and return, so if you look at this baby on the screen with their caregiver, we know that infants and young children need adults that love them to pieces and provide that secure, nurturing care. And if we work with this, with what we know about relationships, we know that they influence every aspect of our work. Every small step that we take, relationships seem to play a part. It certainly does in enrollment. We know that together we can continue to make small changes to strengthen our outcomes. They may not be large, they may not be fast, but we'll make them. And with transparency and openness to learn from each other and involvement from everyone, in the home visiting coin, we use the motto, all teach, all learn, and we're in this together. So everything we learn, we share, and we hope to share that with you all as well. So I just want to talk for a brief second about this relationship-based level of influence that is part of our home visiting coin. So as you see on the screen, the relationships are what really hold our work together. Some of you may have heard Jerry Paul's version of the golden rule, do unto others as you would have others do unto others. It helps us to share a simple reminder that our relationships that we create can carry over into others, and what we really do matters. So the relationships between state leaders and local administrators have an influence on the relationships supervisors have with staff and staff with families and children. So as we've rolled out the home visiting coin, at the onset we wanted to ensure that families, home visitors, leadership were all part of the team with an equal voice. In turn, we hope that this stance will support enrollment, engagement, and retention, because again, it's all about relationships. So if we take a look at our structure, again, these resources can be shared with you. So I'm not going to go into deep detail about the Breakthrough Series model, just briefly go over it here. So the home visiting coin is based on the framework called the Breakthrough Series model. This is a time-limited learning activity, 24 months, that brings together and supports a group of 13 MIECHV grantees that volunteered to be part of the project, and 35 teams from local implementing agencies who are seeking improvement in topic areas of their choice that are of concern to home visiting and are ripe for improvement. So our three areas for improvement are maternal depression, alleviating maternal depression, breastfeeding, increasing the duration of exclusive breastfeeding, and developmental screening and surveillance. So not only doing developmental screening, doing surveillance, but getting kids linked to services and getting receipt of services should they need those. The ultimate goal is to really identify evidence and experience-based practices that can result in breakthrough changes if implemented with fidelity. So this model really helps us to adapt and apply what we know works to multiple sites to accomplish common aims. So it's a nice way to start out a project. Everybody's on the same board, working for the same outcomes. And the home visiting coin also encourages frontline workers, supervisors, and administrators to develop innovative practices for improving outcomes where we don't have robust evidence established yet. That's where family engagement and enrollment comes in. Innovation is the second I in the home visiting coin. It's where the evidence is thin and for which the home visiting coin can provide new insights. So, our goal in the home visiting coin is we know that we're adopting this model for home visiting. The model provides a mechanism for participants to use this cutting-edge research and innovation in on-the-ground practice, and we hope to develop leaders of change who use data on a regular basis to improve practices. It becomes a normal part of the way they practice. Okay, I'm going to move on to the next slide here. So right now, where we fall in the Breakthrough Series model is we have come up with our topics. We've created our background documents to help support our process. We've gotten all of our teams together at a meeting in Washington, D.C. in May, and now we're in what we call an action period. And I don't know any other way to say this, but during the action period, it's where the rubber meets the road and teams are engaging in active work. So this model for improvement is made up of a set of questions that drive our improvement and the plan, do, study, act cycles that are part of the Breakthrough Series model. So each team gets to ask, what is our aim, or what are we trying to accomplish here for our current work to get to this larger collaborative aim? Then teams begin to generate a change idea that they think will lead to improvement, preferably a high leverage idea, and we are disciplined about measurement. We could just begin to try out these new ideas and make informed judgments about whether things are better, but we know that if we want to convince others and ourselves and do right by families, we really should identify something to measure that would allow us to be more objective in answering the question, how do we know that this change led to an improvement? So improvement occurs when a change is implemented, but not all changes result in improvement. We learn just as much from those changes that don't work that do. So when we think about common practices, probably a lot of you can relate to some point in your trajectory of professional life of dealing with this common practice. So in the real world, we often work in groups to design, get approval from higher up, and then implement, which often leads to major flaws in spread and scope because we don't practice first. So if we look at the model for improvement, we test, we adapt, sometimes we abandon, we try something out with just a couple of families, and we think, oh, that did not work. We do not want to do that. We need to change this. So we add some adaptations, and we test again, and we modify until we have proof and data that says this is ready for spread and this is ready for adoption. Oftentimes, if we jump from an idea to full implementation, things can often get worse before we can get to some improvement. So let's get into what we're doing around family engagement. Well, I'm going to talk about the broader scope of family engagement and then hone in on the activities we're doing around enrollment. So the home visiting COIN as a larger collaborative set a SMART aim. So Breakthrough Series research suggests that we can all increase our odds of program success through early definition of our project's aim and early agreement on our theory about what changes are necessary to achieve the aim. So it's part of that messaging challenge that I brought to you in the very beginning to really consider, does everybody understand our message the same? Does everybody know what it is that we are working together for? So for family engagement, we set our global aim as the what we're trying to accomplish as increasing by 25% the average proportion of expected in-person contacts between the home visitor and family that are completed. So content, application experts set this aim based on our current gap in best practice predicated on research. Teams vetted our aim at our first in-person learning session in May of 2014, and enrollment, you'll see, plays a very critical role in meeting this aim. So you'll see this key driver diagram on the screen. It looks a little busy. It could look a little overwhelming, but if you just look, you'll see our SMART aim for engagement. Then in the first column, you'll see our primary drivers. So this is really our theory of change around engagement. The factors that influence the achievement of the aims are the drivers, which you'll see in the columns. While there are many ways to illustrate the theory of change, our project uses a driver diagram that depicts the relationship between the aim, the primary driver, that contribute to the aim, and secondary drivers that are necessary to achieve those primary. So this document helps our collaborative, all of our teams, to have the shared view of our theory of change. It sets the stage, it sets the messaging, and so forth. So by the end of the project, all teams will hopefully have addressed each driver and secondary driver while the changes they infuse are flexible. Right now, all teams are working toward one primary driver until November of 2015 when we meet in person again. So you'll see our first primary driver that's circled in red is timely enrollment of appropriately referred families. So our strategies, well, we can go to the next slide here. Just to measure whether we're meeting our aim in relation to enrollment specifically, We are looking at 75% of our families will receive a face-to-face contact in the home within 10 working days of referral. So that's one of our process aims to get to our final outcome. Our second process aim related to enrollment is that 80% of participants will experience no more than 15 days between home visits during enrollment periods in which weekly home visits are the target. So you can see we have measures. How will we know that a change is an improvement? All teams are reporting standardized monthly data reports online so we can measure collaborative change. But all teams also get individual results via run charts that are populated automatically as they enter their data into the template. So we're collecting the same measures, the same data across all teams. Our current focus of the work, you can see on this next slide here, is you can see a large percentage of our teams are working on timely enrollment of appropriately referred families. So let me give you some ideas of what people are working on. So primary driver one change ideas. Some examples of changes that are being tested. Most of the teams working in primary driver one, or 82%, developed tests of change to reduce the time between referral to the first home visit. So some specific examples include several teams set up an internal tracking system for referrals and first contact, and they measured this, or they looked at this in supervision on a weekly basis. They tried the spreadsheet with one home visitor at a time to see if the tracking system worked, and then they adapted throughout and so forth. So starting small and then moving it on up. Building stronger relationships with referral sources such as WIC to help expedite referrals. Several programs are using text messages to remind families of their enrollment appointment, but again, starting small, one home visitor with 2 families, and then scaling up as they saw success. And another program developed for that messaging piece created new talking points to ensure families really understood the scope of services and they were all talking about it the same. So here is a snapshot. This is only one small piece of our data. As I mentioned before, we're a pretty new, young project when it comes to the Breakthrough Series model. We began collecting data in May of 2014. And what you see are 2 data points on 2 of our run chart samples. So we have many, many other run charts to show, but I picked out one related to enrollment. I want to get really excited that it appears that we're improving, but we just don't know yet. I think it would be false to say that when we only have 2 data points. But after we have 8 or 9 months that have gone by of data, we'll be able to maximize our learning and really see through patterns if we are making an improvement. The run charts are seen by all participants on monthly calls that we have, so we can collectively see variation, special circumstances, which allows us to make mid-course corrections should it be needed. We can begin to see the stability or instability of the change at hand. So that transparency is really important. So what do we know so far? And I think, when we really think about the babies and the toddlers and the young children and families that we support, what are we doing that is really affecting them, really getting families in our door? And I think what we're learning, even though it's early, we've learned a lot so far over this past year. We hope to continue sharing what works. We'll post our data on our dashboard, on our website for everybody to see. We're willing to share our lessons and our resources. But I think one of the most challenging aspects has been to keep our tests small. Family enrollment and engagement is a very large goal that we want quickly, but again, I keep being pulled back from lessons learned from teams to those early relationships, and those small steps can often lead to a lasting bond, or in our case, enrollment and healthy, active engagement. So the bottom line, what we want to continue doing is transparency is golden. We share everything and anything, so we all see each other's data. We learn from the good, we learn from the mistakes, and we keep on helping each other. We have this all teach, all learn trajectory where we're all experts learning from each other. We say, try tests that you can start next Tuesday. not ones that are so large that it takes months of planning. We want to do small tests and scale up. Tap early adopters, those that want to be part of this process, this kind of process, and test first on willing volunteers. I mean, I think there are so many more messages to share, but for the sake of time today, I hope I was able to get some excitement about this Breakthrough Series model and just share the message that we are here to give our information to all of you, and we can't wait to learn more. And we thank all of you who are on the line today that are part of the COIN for letting us learn with you. So for more information, you can go to our website that's on the screen right now, homevisitingcoin.edc.org, or you can contact me directly should you want any of the materials from today. So with that, thank you, and I'm going to turn it back over to Kathy.
Thank you so much, Mary. That was a great foundation for today's topic. We really appreciate you sharing that. We're going to be hearing from Mary again later during the discussion of each of today's case studies. But before we get to the case studies, I want to give you a little bit of a rundown of the format that we'll be using today. So it's a little bit different approach than we use for most webinars. We've chosen a framework that we really intend will support learning among peers who are all faced with the same kind of challenge, and hopefully it will allow for deeper discussion of the processes and approaches that can be applied to overcoming the challenges. So using an interview format, each grantee representative will share their state's enrollment story in 4 parts, starting with a description of their MIECHV program and context related to enrollment, followed by an explanation of the challenge that was evident. At that point, we'll pause for some analytical thinking about the challenge. Mary Mackrain will be joined by Kathy Bodkin, Senior TA Specialist at the TAC, to provide observations and insights based on their work with many states around enrollment issues. Then our grantee guests will share the rest of their story, the steps that they actually took to enhance LIA enrollment efforts, and the results of those actions. And then Mary and Kathy will join us again with a follow-up discussion debriefing the case conclusion. At this point in each case, we will invite all of you listening in to join your peers in the conversation. To do that, you'll use the control panel that's located to the right of your screen. At the top, you'll see an orange arrow, and you can click that arrow to toggle back and forth to hide or show the panel. At the bottom of that panel is an open text field where you can type your questions, which will come to me. As you're listening to each case study, if you have a question or comment or example for the presenter to share, go ahead and type it in. I'll be monitoring the question box throughout this time, and we'll share your comments or questions with our presenters during the debriefing section of each case. So with that, let's get started on our case studies. To present our first case study, I'd like to welcome Rob Colombini. Rob is the Home Visiting Manager at Thrive by 5 Washington, an organization that you'll learn more about shortly. Rob, thanks so much for joining us today to share Washington's experiences addressing the challenges of enrollment.
Thanks, Kathy.
So let's start with an overview of the MIECHV program in Washington. Describe it for us.
Sure. So in the state of Washington, we have a joint partnership between the Washington Department of Early Learning, which is actually the MIECHV lead, and then Thrive by 5 Washington. Thrive by 5 is responsible for the grants administration and what we call the implementation hub for our home visiting services account grantees. And that implementation hub is responsible for centralized TA, for quality implementation of home visiting programs, and really comprised of Thrive staff, home visiting staff, grants management staff, fiscal, et cetera. And an important part of that hub team is our state model leads, specifically parents and teachers, nurse-family partnerships, and parents PCHP. So in addition to that hub team, we also have DEL, our Department of Early Learning, that participates as well. Thrive by 5 Washington, in collaboration with the Department of Early Learning, funds approximately 10 staff here at Thrive for home visiting, approximately 22 LIAs. We work in 17 counties in the state. For MIECHV specifically, we have 2 model programs, Nurse Family Partnership and PAT. In addition to that, in the state of Washington, we also have additional home visiting models, Early Head Start, PFEL, PCHP, STEEP, and CPP are some of the models we work with. We have capacity to serve over 1,700 children statewide, and in addition to that, like many other states, we also are a MIECHV state.
So talk about the strengths and assets, Rob, that you think you were able to apply to enrollment efforts.
Sure. So because this is a partnership between the State Department of Early Learning and Thrive by 5 Washington, we felt it was much easier to leverage with joint communication how important it is to keep enrollment at or above for the state at 80%. The state is fortunate to have home visiting state model leads, like I said before, so we have these great leads that work directly with our programs that are a part of our home visiting hub and a part of Thrive by 5. And so they can work directly with programs in cooperation with Thrive, to assess what is working, what is not working, and then really help provide a structure for feedback.
But in spite of these strengths and assets, you still had LIAs that had some challenges meeting enrollment goals. Is that right?
Yeah, yes, of course. So, first, we always can considerably provide ongoing training and technical assistance to our programs throughout the state. But recently, we finally had a number put to what enrollment needed to be at. And so that kind of shifted in how we provided that assistance. Second, we're really lucky to have a grants management team on board, but also a grants management tracking system that really monitors enrollment on a monthly basis. It provided the data that showed over 3 consecutive months recently if an LIA was below or exceeding the required percentage that we're looking at. And it helped us to analyze the data we could see, and so that we could see which LIA needed assistance.
So as you looked more closely at those individual LIAs that were having issues, challenges, what factors did you identify as that were making enrollment so challenging for them?
Well, just some things to think about. In Washington State, like many other states, our LIAs range from urban to rural. Some communities have multiple home visiting programs which collaborate to serve families, while other communities are the only program for long distances. Many of our LIAs have had staff out on leave, maternity leave, medical leave, and often do not have the resources to replace those staff members. So additional families may not be enrolled, or families might not be seen during that period of time. So some grantees in other parts of the state may have competed for specific ethnicities or city or town boundaries that they plan to serve families, and now are finding that those families may not even be there. So those really are some of those factors.
So let's pause for a few minutes to think about the challenges that you've briefly described, Rob. I'm going to turn it over to Mary and Kathy. As you listen to Rob's description, what are some of the points that stood out to you about what he described?
Well, this is Mary. I'll just start. I think, I was thinking about the likeness to what we're learning about in the home visiting COIN, and I was really intrigued by Rob's explanation about how they really started using these relationships that they already had established between state model leads and local teams to really dig deep to get at all of those unique issues. So it's an interesting idea, and I think it's what a lot of people already do, but you think about this big problem of enrollment and how your strategies and changes and things that you put into place may look very different because of the diversity that Rob really shared with us. And I just think that's an important one to keep in mind, because our states are diverse, right? And we can learn so much by just opening up the dialogue and building those relationships.
And this is Kathy Bodkin, and just to continue with that, I think that I am struck about the diversity that you mentioned, Rob, the number of LIAs, the number of counties, and just how diverse the populations are you're serving. But I think it's wonderful that you also were considering the staffing and the challenges internal to the program itself and what that meant at the community level. And not just a formula or just looking at the population, but really looking internal to what the challenges are at each local site.
Well, thanks for those comments, Mary and Kathy. I think we'd all like to find out exactly what Rob and his team in Washington did to address some of those challenges. So, Rob, why don't you talk about the steps that you took?
Sure, and just to comment on that, Kathy, it is a complete team. It clearly was not just me. It was a complete team that pulled this together. But really, the state of Washington took a proactive approach to increase MIECHV home visiting LIA enrollment. The Department of Early Learning partnered with Thrive by 5 Washington to structure a detailed training and technical assistance plan that would involve planning, implementation, and monitoring around enrollment. So working with, again, our home visiting state model leads, and specifically parents as teachers and nurse-family partnerships, Thrive assessed each LIA under the expected percentage of enrollment and worked with them to raise those numbers. So parts of that process were a joint letter that was created, stating expectations to LIAs. The home visiting manager, which is me, joined their state model leads monthly calls. So these are existing systems that are in place that our model leads already do. They work with their programs on a monthly basis. I was lucky enough to be able to be part of those calls, and they worked me into that process so that it seemed more seamless. And then during that time, we provided some basis for next steps for LIAs. Some discoveries that LIAs different widely in their understanding of how to enroll families. And we also learned that there's so many barriers to enrollment.
So talk about the issues that you narrowed down to address with those LIAs.
So we think the issues were different for each LIA, but really some trends across the state were that we had lower enrollment due to staff out on leave, multiple grantees with staff out on leave. Referral processes needed to be strengthened, and we needed to dive deep into what those processes looked like. We had basic understanding of what goes into recruitment and working with other programs in the community to build a referral basis. So again, those pieces really needed to be strengthened.
And talk about the process of solving this challenge and addressing those issues.
So again, our approach started with joint calls with our grantees. Our model leads already are having these calls with grantees. So again, it was natural for me to be a part of them and then part of that call with the LIA management staff. We discussed what was happening in the state with regards to enrollment. We explained the need to be at a higher percentage, and then we presented any grantee under 80% with our implementation improvement plan. The grantee was then asked to complete the plan and submit it to Thrive for our hub review and comments. So again, the grantee worked with their home team to come up with a plan to how to increase enrollment. Thrive and the state model leads then scheduled site visits or scheduling site visits. During this visit, it's just a way for us to plan and discuss, provide suggestions for improvement. And then following the visit, a request from Thrive's grants management database was sent to the LIA so they really could upload that plan and make it part of our system as well as a part of their grant. A big key to that plan, though, was asking for signatures from really the highest management point in the agency. So we're asking for signatures on that plan from the CEO or the highest management so that really we can demonstrate some urgency of this issue, and that seemed to really help us and help the LIAs in understanding the urgency. Then grants management continued monitoring those plans for monthly enrollment numbers after they've been submitted.
And why did you feel like that improvement plan process was the best option for your LIAs?
Really for us, each LIA has a different need. Essentially, each program receives individualized training and technical assistance. So one program may have one need, the other may have another, and we felt that it wasn't just a blanket statement to be coming out and saying, do this plan, but how could we work together to see what those needs were. The main solution for the enrollment issue is this implementation improvement plan. The plan really gives structure for grantees to organize around and Thrive the ability to monitor to fidelity and to contracts.
And so have you been able to see any results yet? I know you're early in the process, but talk about where you are in the process and what you've been able to see so far.
Sure. LIAs have been working really hard to assure enrollment is at or above 80% in the state of Washington. There has been a slight increase in enrollment numbers. the time frame really has been short, like you said. LIAs received letters in July. Coaching calls have been completed with all those programs under 80%. Site visits right now will be completed by the end of August, if not by the 1st of September. And then also during this time, some of our LIAs are participating in the MIECHV research. So they're kind of juggling a whole bunch of things at this time. So some of it will see dramatic impacts on enrollment, and some of it will be a little slower. We're really starting to see effort by LIAs to improve enrollment. And then we're also starting to see slow improvement for enrollment numbers. Again, it's been a very quick turnaround. We just really started with the letter going out in July.
So talk about what you expect to see as you have a chance to implement it further.
I think I said it earlier, but we're really lucky to have a grants management team in-house here at Thrive. They have the ability to analyze the data that's coming in from our LIAs. With the first set of improvement plans that have already come in, and they're already in our GIFTS, which is our grants management system, we're excited to see trends across the state. We'll be able to sort the data from the improvement plans. And in the improvement plans, it's broken out by 3 different areas: outreach, managing referrals, and then in retention. LIAs are documenting their barriers and strategies in all 3 of those areas. So by the time all of them are submitted, we'll have documentation on what the Department of Early Learning and Thrive can do to support enrollment in all those areas. For example, one of our LIAs has asked for assistance with communication between the LIA and their local DSHS office. So how can we help spark or promote some of that communication? Some of our next steps specifically are additional and continued site visits. We're also continuing to assess the effectiveness of this process. And then we're also looking at our expectations for success or even potential failure. So lastly, I think we're working on strategies for addressing that staff leave process, which we've noticed across the state is pretty evident.
Well, I think probably some people will be disappointed that you don't have an answer to that one yet.
I know. Yeah, definitely.
We'll have to come back for a part 2 maybe in 6 months or so.
Sure.
Well, thank you, Rob, for sharing the work that you have been doing, the processes that you've undertaken, and now it's time for us to have a little bit more of a debrief and talk about what other states can learn from this case study. And for those of you listening in, this is where we would like you to join in the conversation by contributing your questions and comments in the question box. Post your thoughts in the question box, and I'll share them as we go. And Mary and Kathy, I'm going to turn it over to you. By the way, we do have a question that has come up already, so we'll pause after you've had a chance to make some initial comments or ask Rob some questions if you like.
Okay, thank you, Kathy. This is Kathy Bodkin. Rob, I'm curious about how you got the buy-in from the home visitors themselves. I think it's great that you used the coaching with the LIA leads and developing the plan, and I just wonder if you could speak to the process of getting the home visitors and what their role was in the developing the implementation plan.
Sure. I think just to clarify too is we are really lucky to have these state model leads that have these incredible relationships with our LIAs. So our LIAs know them really well, and so when I think our state model leads are asking questions or have specific areas that they want to work on, they've got this direct connect to them. So I think each grantee is different. So many grantees want to have their management team to be a part of these conversations and to take the lead. But many also bring to the table the home visitors or the nurses that are working with the program. So I think we just need to give credit to those model leads because they've created those relationships. And then it just makes it a lot easier for us to want to have further conversations around enrollment.
Thank you, Rob.
So, Rob, this is Mary Mackrain. I just want to ask a quick question. One of the things that you mentioned was the wide variety across programs and operationalizing enrollment or talking about enrollment. There was a lot of variability, and it may be too soon to tell. But from the work that you've done thus far, is it your sense that you're starting to reach a common understanding of enrollment, what it is, the process across teams? Do you feel people are getting on the same page?
I think programs realize the intensity of what enrollment is, and they understand the intensity of wanting to be funded. So I think that, yes, they're jumping on board to make sure it happens. But I also want to step back, too, and say that really we're looking at this from a systematic standpoint. It's not just that we want to jump in and say, yes, your enrollment has to be up, and I know that has been a focus, but it also is what are your true barriers and what can we do as the implementation hub from Thrive and our model leads do to assist you in moving forward. So, yes, I want to say that everybody understands what that is, but I also think that it's going to take time for us to help really dive deep to understand truly where grantees are and how we can help them. So I think some grantees have been in operation for many years, and they might have systems in place already that they can, jump on and move forward on, and other grantees may need a little more time and some assistance to dive deep. But I think we're moving. I think it is a little too early to tell, but I think we're going to see movement that demonstrates really how you have to individualize your TA for grantees. And again, it can't just be this blanket, good luck, and we'll see you on the other side.
Well, it sounds like your intentional individualization is a really good lesson learned, even at an early stage. So that's great. Thanks for sharing.
This is Kathy, and we did have a question come in, and I'm wondering, Rob, you may have addressed this somewhat already,
sure.
and if you have more to add, please do. But I think Mary and Kathy, you might also have a response for this. The question is, what supports can states provide to programs early in implementation that are still trying to figure out their true capacity?
Well, I'll start just to say I think we're also very lucky. We have Liv Woodstrom, who has been on our team and most recently just got done with what we call our rural projects. And for those projects, she really went to each community, met with each community, and helped with our model leads foster communication to understand what the true need is in the community, and then also kind of think and look at what the potential home visiting models could be in that community. So what she did was kind of get a sense of what they needed and then what was the best fit, and then talk to them about, what lessons learned have been across other agencies. So if you have the capacity to do that, I would strongly urge you to think about how you can get out there prior to even funding a program to better understand what their needs are. But then and if you do fund a program, that process continues with the staff to build, to foster them along and understanding, what works, what doesn't work, and really what does model fidelity demonstrate that can actually be done.
Thanks. Mary, I wondered if you had any comments.
I'll make it quick, but I know that this isn't speaking in perhaps to the home visiting COIN, but I know in some of the other work I've done, teams have found it really beneficial to engage in a gap analysis or environmental scan at the very onset, as Rob also alluded to, that it's just good to know where you're starting, what you have in your community, what the partnerships are, what's the capacity out there in the community already, so you're not duplicating services or stepping over each other and so forth. So I think those are two processes that can be really beneficial to new projects.
And this is Kathy, and then I think you have to have a good schedule for what you expect your enrollment to be. If you're expanding an existing program, it's very different than starting a new program. Just how you want to stage those enrollments, and maybe there are pockets, like Rob explained about working with WIC, that you're trying to develop the relationship, and so you need to have some realistic goals, not just the formulas from the model, but you do also need to have the models on your planning team about what have they seen across the country as programs are being implemented. And it's a very different thing to scale up from a small program to a larger program versus initiating a program. So some realistic goal setting and advice from the models, and the state leads really talking together with the site about how this is going to flow, so that 6 months in you know if you're on track, and if not, how to change that.
Great discussion. Thanks to everyone. We don't have any other questions that have come in, so why don't we go ahead and move on to case number 2. Here to share Virginia's story about facing challenges of enrollment is Mary Beth Cox. Mary Beth wears several hats, as I know many of you do, one of which is the Home Visiting Program Specialist, coordinating CQI activities for MIECHV in Virginia. Mary Beth, thank you so much for being with us today.
Thank you, Kathy, and hello to everybody listening in.
So why don't you describe MIECHV in Virginia for us?
Okay, I'll be happy to. So I work at the Virginia Department of Health. We are the administrator of MIECHV funds for Virginia. Here within our office, we have 5 staff who comprise the MIECHV team. Our MIECHV program funds 18 contract sites to expand home visiting services in 25 communities across the Commonwealth. Sites implement 3 models, so healthy families, parents as teachers, and nurse-family partnership. And we have several LIAs who do both, actually. MIECHV funds also support some supplemental mental health and nursing staff for approximately half of our LIAs. And MIECHV partners with 2 universities in Virginia to evaluate a promising practices project in 3 communities and a centralized intake project in 4 communities. I also want to share that we have 3 LIAs who are in the national COIN, and we have really great relationships with our in-state model partners, or regional and in-state model partners for the 3 evidence-based programs, and also a home visiting consortium which really supports and enriches the work at MIECHV here.
Well, it sounds like you have quite a lot of assets, so the next slide is especially appropriate. Especially talking about the challenges of enrollment, what would you identify as the assets and resources that you had to work with?
So the first thing I would emphasize is our team here at VDH, our MIECHV team. We have a great team, and many of us have been home visitors, so we are really familiar firsthand, kind of like Mary was talking about with, knocking on the door and hoping that they answer. And so we've experienced the complex issue of enrolling and engaging families firsthand. Our team also brings skills, knowledge, and experience in continuous quality improvement, which is how we've decided to approach our enrollment, and I'll be talking about that. But my background includes program evaluation and coordinating learning collaboratives, coaching, and helping local agencies use data to inform practice. So our team has been key. And then we intentionally designed our CQI plan around a learning collaborative approach, which I think really helps set the stage for a supportive, sharing environment, not punitive at all. And finally, we engaged the excellent expertise of TAC and the Dove Center, specifically Kathy Bodkin, who's on the call, and Dr. Darrow, Mary mentioned earlier, with her integrated theory of family enrollment and engagement. They've been so helpful as expert consultants on our project.
So now let's get into the challenge. Describe the challenge that became evident to you around enrollment.
Okay. So about 2 years ago, less than that, when we were planning our first learning collaborative, we brought our state CQI team members together to review data and determine what topic we would be focusing on for our learning collaborative. So our state team included our state model partner leads, as well as 3 local agency representatives, 1 from each model. So we had different perspectives at the table. And we examined implementation data as well as some benchmark data. And at that point, our MIECHV sites were at approximately 50% of enrollment, or we looked at caseload capacity. And so our team quickly chose enrollment and engagement as the first topic. So going forward, topic chosen, the next series of challenges became quickly apparent. There were differences across home visiting models and even among local agencies implementing the same model sometimes. In terms of what factors were contributing to low enrollment or engagement, again, we've kind of alluded to it's a very complex issue. Definitions of enrollment, staffing to support outreach and enrollment activities, and a variety of skills and tools to collect and analyze data related to engagement and enrollment. So our challenge was, at that point, how could we help all sites improve enrollment despite taking into consideration these differences?
Yes, that's the theme that we've heard before about diversity across LIAs, right?
Yes.
So let's take a pause here. Oops. Hang on. Oh, let's not take a pause. Talk about what, once you saw that was the challenge, what was it that you knew that you wanted to work on, that you wanted to achieve?
So to help figure that out, we conducted a survey of the sites that would be participating, which were our first funded sites, the formula sites, because they had been basically up and running for 1 year. So those 8 sites were our first group. And we surveyed their knowledge, attitude, and practices related to both CQI and applying CQI techniques to improving enrollment and engagement. So some of our findings were that in general, sites did not have a formal process for conducting continuous quality improvement, and they had never done a CQI project specifically on enrollment and engagement. And notably, the home visitor scores were lower typically than the supervisor scores. They tended to not be familiar with the data being collected on enrollment and engagement and what it was being used for. So the 3 goals we set were really in line with the model for improvement and what we learned. So the first was we wanted to help sites build and implement formal supports for continuous quality improvement. And the second was to support sites in using a team-based approach to conducting CQI. And finally, to help sites apply their CQI knowledge to the topic of enrollment and engagement. So those were our 3 goals.
Great. So now let's take a pause. Sorry about jumping the gun. Mary and Kathy, as you were listening to Mary Beth describe Virginia and the challenges ahead of them, what were your thoughts?
Well, this is Mary. I'll just speak. I think I just have this sense of excitement for your group as you go forth, because it sounds like Rob as well, that you you very much dug deep into where are all of the teams at. You have this framework of teaming built already, which is such a strong way to start. And knowing that there needed to be some awareness building and supporting people where they're at. And I also heard this willingness of leads to reach out for assistance, so perhaps modeling what you hope to see local teams do in that kind of all teach, all learn practice. So it sounds exciting, and I can't wait to hear more about what happens.
This is Kathy. I also am impressed with the way you use teams, both to help all coming together and creating a forum for the teams, not isolated individual site teams, but really pulling them all together and sharing, recognizing where different strengths might be, and seeing this as a challenge for the group itself and how they could bring their skills together.
Thanks for sharing those insights, Mary and Kathy. So let's find out, Mary Beth, what you and your team in Virginia did do to address these challenges. What were the first steps that you took?
Okay, so the rest of the story. In April of 2013, we launched our Learning Collaborative, which we at first thought was going to be 6 months, but quickly determined it needed to be 18 months. The formal approach we selected was the model for improvement, which Mary has already talked about with the plan, do, study, act cycles and 3 questions. So through this learning collaborative approach, we worked towards our goals, which I listed previously, by providing the activities you see on the screen. So we have done, well, we have 1 more to go, but we've We're going to do 3 face-to-face learning sessions. We do monthly webinars or teleconferences. These are typically around a issue that sites are struggling with, or to review data or a tool or technique, or for sites to share what they're doing. We do quarterly or as-needed coaching calls. So I've been acting in the role of coach during these calls. Sometimes they're site visits. We do a weekly e-bulletin to keep everybody up to date with upcoming events, resources, and finally, we have an online communication forum. It's a website where we post all the documents related to the Learning Collaborative, resources. We have a discussion board on there. So this is what we're providing.
Okay, so that's the process. So talk more about what the key issues were that you were focusing on.
Okay. So through all of those processes, we worked to help the LIAs, and I would say it was really a bidirectional. So we all kind of helped each other achieve the things that you see listed on this slide. But during the group calls and the individual coaching calls, we really went back to these core ideas. First, utilizing a team approach. So we encourage sites to not just keep it at the supervisor level, but to bring in definitely the home visitor perspective is really critical. Data entry staff, anybody that will have a role in that enrollment process, sometimes even an outsider, a partner at a hospital. And next, we help them develop SMART aim statements. I'm sure everybody is familiar with the SMART acronym, but we help them walk through what it took to craft that aim statement, and then to plan and test small changes, doing the PDSA cycles, and trying to keep it simple and using evidence and research to inform the change strategies. And next, helping them use data to drive decision making. So how do you collect baseline data? How do you make data transparent? How do you make tracking tools and run charts? And finally, we really created a forum where LIAs could share information and strategies about what they were finding that either worked or didn't work in some cases, but they shared that with each other.
So talk more about the development of the AIM statement with those LIAs.
Yeah, that was a really exciting part, actually. It was all exciting, but so sites developed their AIM statements really starting at the first learning session, and many continue to refine them over several months. So at the first learning session, a key kind of aha activity that we did was every team got training and then dedicated time to do a process map of their enrollment and engagement process. We called it from stranger to engager, so the family going from a stranger to being engaged. And it forced them to work as a team and think critically about what the process feels like for families. So during that exercise, most realized that either the period between referral and enrollment was longer than they wanted it to be, or that families referred to their program were often not eligible or not from their target population. So these are, again, echoes of what has been stated before as common challenges. But their AIM statements fell kind of into those two buckets. The first would be to reduce the time it took to enroll a family, and sites tended to land around this 14-day period, within 14 days. Or another group of sites worked to improve the number of referrals or the eligibility of referred families through better outreach efforts. So they really worked on that. I want it, I'll try it kind of period.
So I think everyone loves to hear an example. I'm wondering if you could go into a little bit more detail with one of the LIAs that you worked with.
Yes, and I'm really happy to do that. I love working with our LIAs. That's my favorite part. I really admire the work they're doing. So the site that I'm going to highlight, little show and tell, is the Up Center. So the Up Center is a nonprofit with strong community ties that is located in Norfolk, Virginia. Norfolk is on the eastern part, on the close to the ocean, and it's a fairly urban, bustling, diverse community. The Up Center uses the PAT, Parents as Teachers model, and MIECHV supports a supervisor, 3 home visitors, and supplemental funds for mental health counseling at the Up Center.
And talk about the challenges that you saw there.
Okay. So So the process map activity that I was telling you about was really a Kickstarter for them. So after the process map, they went back and they looked at some baseline data. They were really concerned about that time between referral and first contact. So they had some team reflection about that lag, and they realized that often that first contact was more than 30 days. And they hadn't realized that, and they were not very happy about that. And they realized that their enrollment process was not consistent across home visitors. Everybody kind of had a different idea of what they were supposed to be doing. And their data system was not adequate to track referrals through the system. So they really wanted to tackle those three things.
So talk about implementing the model for improvement with them.
Okay. So I'm really oversimplifying the work that we did for the purpose of telling the story. But their aim, just focusing on that, wanting to enroll families within 14 days, that was their aim. So working as a team, they devised a new process, which they actually wrote down and they put it in somewhere where everybody could see it. And they tested this new process and refined it over a series of weeks and months. To study their progress, I helped them create an Excel tool, which was like a tracking chart, which automatically fed into a run chart to track their progress. And they would meet monthly, which is part of their act. They would meet monthly to check in and review data.
So talk about the results that you've seen.
Okay. So what you see up on the screen, it's a little hard to tell, but it's essentially it's an adaptation of a run chart for them. The red line is their 14-day goal, and the blue points it's for each family, the number of days between what they call the parent introduction or the referral and the first home visit. So it took them a little while, so they didn't start collecting data until December because of their data system and the TA needed to be able to create the tracking tool and so forth. But since they started tracking the data and refining their process, they've been able to consistently, over the past several months, get that time to less than 14 days. And I want to share with you a quote, which I think is up on the slide. It was from the project supervisor. I called her to get her help in creating this presentation, and I think it really represented a turning point for her. She said, it made a big impact among the staff. The tracking tool helped the most because it helped the parent educators see their numbers. They did not realize how long they were hanging on to referrals. So they really felt empowered by looking at the data every month and proud that they had created a new process together to achieve their goal.
And I just wanted to mention, too, for those of you listening in the packet that you received yesterday in your email, I believe one of the resources at the end of the PowerPoint, we included just kind of a snapshot or a screenshot of the Excel run chart that Mary Beth is talking about, as well as this page that you're seeing here. So, and I'm sure that Mary Beth would be willing to respond to any questions that you had if you wanted to contact her more about the run chart and the use of data and how they use that.
Right.
Is that right, Mary
Yes.
Beth? I just committed you to something.
Yes, definitely.
So talk about the results that you've been able to see across all 8 LIAs as well as the Up Center.
Okay. So that's the big question, right? So did enrollment improve across the 8 sites? And to be frank with you, that's been really challenging to discern. So issues related to enrollment and caseload are complex, and sometimes they're related and sometimes they're not. But based on the limited data we have available across all of our 8 sites that we're participating, we can really only say that caseload capacity has increased. That's a distinction from enrollment rate. That's not enrollment rate. That's caseload capacity. But it has gone up from 52% to 63%. since the collaborative began, and there's a wide variety within that 62%. There's a number that are, above 80 and a number that are struggling with staff issues and, below 62. But I'm not sure I wouldn't hang my hat on saying this is due to the collaborative. What I really do feel is at the local level, the sites are well on their way or have already reached the goals we set out for the collaborative. So all sites have worked really hard to build formal CQI processes, like having team CQI meetings, developing aim statements, using PDFA cycles related to enrollment. They are all using run charts to track data in real time, and all sites have applied CQI techniques towards improving a key aspect of enrollment that they identified themselves. And many have achieved their initial aim statement or decided to abandon it because what they were trying to do was not working, or they've adopted new or additional aim statements. I also want to share that there have been some positive, kind of unexpected outcomes. I think on my coaching calls, I really detected for those teams that were maybe struggling with this to begin with, that they've kind of turned a corner and improved. It's actually improved their teamwork and communication by having these conversations about data and how to improve something together. And including home visitors as part of the CQI team, asking them to be directly involved in reviewing data and devising improvement strategies has really been critical in that communication and team building. And we've had at least one community that I know of that's really embraced the model for improvement in the PDFA cycles, and they have introduced them at their community group to use in a project that community group is doing around enrollment.
So what do you see and what do you hope to see in the weeks and months ahead?
So what you see listed on the slide are the things we're going to be doing in the future. So we are wrapping up our current Learning Collaborative in October, and we are planning right now to expand the Learning Collaborative approach to all of our 18 sites by the spring. Still figuring out what that's going to look like, but we do want to incorporate our program model partners more into the CQI process. And we have revised the new contracts for the LIA going into next year to include more clear caseload target expectations, and kind of similar to the approach that Rob presented in his story. We will be assisting LIAs that are not meeting an 85%, so we've set a threshold over a 3-month period to develop an improvement plan, probably incorporating these CQI techniques into that improvement plan. And we've already started providing LIAs with monthly caseload and visit summary data reports to kind of start feeding into these new components.
Well, thank you, Mary Beth, for sharing Virginia's story. Mary and Kathy, I'm going to turn it over to you for your thoughts, but just a reminder to everyone listening in, if you have a question for Mary Beth about the work that they were doing in Virginia or the work specifically that they did with the UP Center, go ahead and submit those questions. Or if you just have some general questions about enrollment challenges in general that you want to pose to the group, go ahead and write those in. Mary and Kathy, I'll turn it over to you.
Okay, thank you, Kathy. I think, Mary Beth, I know you've worked really hard on this, and it's been important how much you've helped the teams define their roles, and as you said, involving the home visitors was an important piece of progress. And I wonder if you might be able to share what you learned about the time expectation in the process, and perhaps any other insights into your role as the state lead.
Sure. So I think I had, so with respect to my role in this, I was really serving as both the coordinator of the Learning Collaborative and the coach. And just as an FYI, I'm only technically 50% on this grant, and this is only about a quarter, or maybe half, probably more than that, of what I do. So maybe, I'm supposed to be spending 2 days, maybe a day, a week, but it takes. I think it's been adequate that amount of time so far, but working with LIAs, it's not going to be adequate, and it was a bigger lift for some sites than I really anticipated. And so that was kind of a good insight, which is why we expanded the timeline from really 6 to 9 months to 18 months, because when we really got into the meat of doing the aim statements, we realized how much of a shift this is going to be for some of the sites who were not accustomed to using data this way, to approaching QI this way. I don't know if I answered your question, but
I think one of the things that you mentioned is the length of time, the amount of your time, and also the idea that teams are all at different places. So that I think those are realistic points to make, and to have people think about the sites that they're involved with and what is a realistic change that can happen.
Right, and that's why we really want to bring our program model partners more into the process. So if I could just say, 2 seconds about that. They've been involved with this CQI Learning Collaborative they've come to the learning sessions, they're invited to the monthly calls and the coaching calls. Scheduling has been challenging, but I know that they've supported the messages when they've had their interactions and their site visits with sites related to, the program model activities. But in the future, we really hope to incorporate them more in helping the sites implement the model for improvement and using the data techniques. And our program model partners have expressed a real interest in getting additional support and training to help sites do that, because not all feel like they maybe can do, the type of coaching that we've been doing through the collaborative around using data and developing run charts and things like that.
That's great. Thank you.
So, Mary Beth, this is Mary. I just have a quick question. I think, you talked about this a little bit already, but I just wanted to know if you had any other lessons learned for a lot of us on the line. You mentioned this wide variation in teams' knowledge and use of QI practices, which can sometimes be daunting, I think, looking at it from that viewpoint. So any other just particular lessons learned for others, maybe diving into this breakthrough series model for improvement that you might recommend thinking about in terms of really supporting all? Right.
Yeah, so I have 2 kind of things I would say to that. And the first is to really make the distinction between quality improvement and quality assurance. That was the biggest aha moment. Was a lot of sites would say, oh yeah, we do, CQI, and to some degree it was quality improvement, but most likely what I encountered was it was more quality assurance. So making that distinction, and one way we did that was at the first learning session we did an exercise we would present kind of a scenario, and we would say, is this QA or is this QI? And then the next question would be, how do QA and QI overlap? How can you use QI techniques to assure quality? And that kind of feeds into my second comment, which is the biggest, I think, moments when I felt on coaching calls that the supervisor really bought into the Model for Improvement PDSA was when we had a discussion about how to align their CQI efforts with other requirements, either from their model or from their agency. So at first they felt like what we were asking them to do was to improve enrollment doing something additional to what they were already doing, and it felt like a burden. But when we talked about how you could do CQI towards meeting a standard that you're already expected to meet, just using data and, tracking your improvements towards meeting that standard so that those two things aligned, then it was like a big sigh of relief. Like, oh, that makes so much more sense. So those were really kind of critical moments.
So that's a big one, though, just working to align with local agencies' internal beliefs and strategic goals. I think that's a really good one to pull out. So thanks. Thanks for answering my question.
Mm-hmm. This is Kathy. We do have a couple of questions that have come in. I'm going to ask the more specific one first, and this is for you, Mary Beth. Was there any pushback with use of the tracking tool document? Was there resistance? Was it initially when you introduced it?
That's an interesting question, and I would say actually no, because the tracking tool kind of came in after they had already established their aim. So they figured out what they wanted to achieve, and they and I would say this was across all sites that I helped develop the tracking tool. They had set an aim, and they were like, okay, how will we know? How will we know if we've achieved the aim or if we're making progress toward the aim? And so actually the introduction of the tracking tool was kind of like, oh, this will be actually really helpful. So first we would look and see if they already had something available, right? So because one of my mottos is you use the data you have. You maximize the data you have. You don't start tracking or creating or collecting something new if you already have it. So what do you have available to you, first of all? And if you don't have it available to you, how can we collect it in a very simple, concise way? Who's going to collect it? And I actually have a little tool that I developed for them to help them think through those questions. But by the time we developed the tracking tool, they wanted it because it would help them track their efforts, all of this hard work they were doing, and to see if it was actually resulting in improvement.
Thanks, Mary Beth. I think I'll ask this question that has come in, and I think anyone could answer this. Rob, Mary Beth, Kathy, Mary, anyone, just jump right in here. It has to do with whether or not home visitors are equipped to deliver the same message, build the needed relationships in regard to additional enrollment demands with MIECHV, or do you think that there might be a need for increased and specialized trainings for home visitors around the skills needed to build enrollment?
So this is Mary Beth, and I'm sorry I'm talking so much, but I have a quick. So we actually asked them at the beginning of the Learning Collaborative, is that what you need? Do you need more training on enrollment and engagement? And we're pretty much heard, at least in Virginia, a resounding no. Like we've gotten so much training, it's coming out of our ears about how to enroll and engage families and create relationships. And we have, through our home visiting consortium, enrollment and engagement training. I think probably the models each offer something. I think what they were really hungry for was, how do we know if what we're doing is making an improvement? We're trying all these things. We're throwing a lot of darts at a dartboard, and we don't feel like we're getting anywhere. So I think I'm not saying it was the silver bullet, but using a CQI approach was really key. And then okay, we don't need more training. We just need a concerted effort around trying things and seeing if they work.
This is Mary. I would echo what Mary Beth just said as part of thinking about what people are working on in the home visiting COIN as well. When we look at enrollment, I think what people are beginning to dive into is making enrollment part of the everyday regular conversation in supervision that's already provided. Making that data also available as part of the regular conversation, so they know what they're doing is working, and if it's not, they can make a change. So that ongoing support, I agree. I mean, I think, of course, some training is always good, but it seems like people are leaning towards that ongoing reflective and administrative supervision and building it into an ongoing process and ongoing dialogue as well.
And this is Rob. Just a quick comment, too. When we sat down with grantees and walked through their implementation improvement plan, they really dove deep into those multiple areas of outreach, of managing referrals and retention. And at that point, we would talk about what there was as far as needs for their home visitors. And sometimes there was a need for training, but sometimes there also was just a need for strengthening the existing systems that were in place, so that everybody knew exactly what the process was going to be for maybe even accepting just a plain referral. So I think diving in and getting a sense of really what's working and what's not, and then potentially adding to that process helped us in our role.
Yeah, Rob, I think that's a really good point, that sitting down and having those conversations is really one of the values. I know I sat in on one conversation, and the group was surprised to realize that there was still a person in their agency that was receiving something that none of them knew. It was sitting on her desk for a couple days. You know, they just didn't know she was even part of the process. So sometimes just sharing the common knowledge and really being able to have the gift of time and luxury to focus on something in depth that everybody's concerned about really does lead to the new solutions.
I think we have time for one more quick question, and I think Mary Beth, either you or Rob could probably answer this. When did you feel local leadership really turns the corner on enrollment, and how did you know that? How did you sense that the local leadership sort of got it?
I'm embarrassed to say this, but I think most of our programs knew that it was important, but once, there was a number set and there was a slight push because we want to continue funding, we want to be really proactive, I think that helped a little bit. And so, I want to say it's because of our intense work and our detailed planning, which did help, I do believe. But I also think it's a reality check. It's a reality check that, there are many programs around that are very focused on the percentage of enrollment, and now we are in that game. And so that I think for us that's helping.
Yeah, and I would echo that. Local leaders get it. They understand the importance of enrollment. I've been in home visiting for almost 10 years now in some way, shape, or form. Enrollment, it's kind of something everybody talks about and pays attention to. For us, with our learning collaborative, what they really got, those aha moments, really came around the aligning and around the process map. So when you could really visualize, maybe what their referral process felt like to a family, those were the aha moments for our teams.
Well, this has been a great conversation, and I hate to cut it short, but we're coming to the end of our time. So a big, big thank you to each of our presenters, Julie, Mary, Rob, Mary Beth, Kathy. We so appreciate your willingness to share your experience and perspectives with our MIECHV grantees as we all try to think of better ways to reach the families who can benefit from home visiting services. For those of you who are listening, if you have additional questions for any of today's presenters, you can find our email addresses in the registrant packet that was sent to you before the webinar. A word of thanks as well to Tracy Hardig and the rest of the TAC team at 0 to 3 for making today's webinar happen. Let us know what you thought about today's webinar by taking the time to complete the webinar evaluation that you'll be receiving soon in an email from WRMA. We truly do rely on your feedback. We do read it, I promise. We need it to guide us in creating better learning experiences for you. And then just a couple of additional notes before we end. In the next couple of days, you will be receiving a separate email from the TAC with related links and resources, including a link to the audio recording of today's webinar, which you are welcome to share with your colleagues. Just to note that due to the frenzy that we all experience that accompanies the end of one contract year and the beginning of the next, we will not be conducting another webinar until November. But you can always find resources on the MIECHV TAC website, as well as the monthly newsletters. You can find video recordings of all of our previous webinars, as well as a bunch of other resources. So thanks again for joining us today and for all that all of you do every day to support families. Thank you and take care.
And that does conclude today's conference. Thank you for your participation today.